It looks like no, but that's okay. I don't know, Peter, if you can, if they're in the
Yeah,
non-panelist.
I'm gonna look. Yeah.
Yeah. Okay, so good morning. So the spine surgery care pathway is something we've been working on now for about 2 years. Many hours with many meetings and surgeons, and I'll elaborate on that. But we believe we're ready to unveil it, and I think it's a very exciting thing because at the end of the day, what we're trying to do in Cliff Note version is provide benefit to surgeons and streamline our preoperative, intraoperative, and postoperative pathway, benefit patients through more efficient care, and increase efficiency in spine care in general. And I think we've been able to narrow this down to pre, intra-op, and post-op categories, and I think we've made some significant strides forward that really will make an impact. This is something we've all heard. Why hasn't PT come to see my patient yet? And it's 3 p.m. And I think that that's just one of the many things that we all gripe about at different times. And this is just one way we were able to settle a lot of these commonplace complaints that myself and others have had. So over the past few years, it's been developed. It's a collaboration between neuro and orthopedic at MSH, MSW, MSM, Mount Sinai, South NASA, and Brooklyn and Queens to be explored in the future. I think this is like the pilot program that we hope will be unveiled throughout the system. You see the participating surgeons, and if Amanda or Jeremiah are on the call, they've been extremely, they have not missed a meeting, and they have been really critical to getting everything that I will present today accomplished. Executive sponsors being Joshua Betterson, Andrew Hecht, and Lisa Galatz. So of equal importance, we've had a lot of partner meetings with physical therapy, social work, infection prevention, medicine, geriatrics, anesthesia, pain management, obesity medicine, bariatric surgery, etc. All of these meetings were separate Thursday meetings where we'd have, for example, a focus on obesity medicine and bariatric surgery. If you have a patient who has a high BMI, how are you going to get them not just plugged in with care, but also not have it take a tremendous amount of resource to get them there? Goal of everything here is to build an optimal process for spine surgery care to improve outcomes, efficiency, equity, and patient experience. So here's another clinical correlate. I'm planning to do an elective L4-5 MIS TLIF. My patient smokes 4 packs a day. Should I do it? The answer there is obviously no. Who should I send the patient to help them assist in quitting? Maybe addiction counseling, maybe psychiatry. We're going to answer these questions. How can I do this without making 10 phone calls and getting patient appointment for September 2026? This is what we are trying to tackle with this spine care pathway, and I think we've done it. So a busy slide. There's one pre-op, one intra-op, one post-op. This is the nuts and bolts of what's going to be done. Smoking cessation, critical to any spine surgery, really critical to any surgery, but minimum 2 weeks of quitting pre-op. Longer for some types of surgery. For example, if you're doing a fusion, I think 2 weeks will accomplish nothing. And there are certain things, there's a lot of places where you'll see the word consider. This is because we didn't have enough uniformity of surgeons to say you must, for example, test your patients for nicotine. But it's something to consider. I do it for my patients who smoke because someone can say they quit and didn't actually quit. And I feel that strongly about it. I think it's worth testing the patients. But that's not a hard guideline, but these are things to consider in the preoperative pathway. Diabetes, osteoporosis, anybody with diabetes, higher risk for infections, pseudoarthrosis, get an endocrinology consult. A DEXA score of -2.5, which would qualify as osteoporosis. You want to get the patient plugged in with endocrine to optimize bone health. For an elective spinal fusion, the literature supports starting the patient on something like Forteo for at least 3 months, and then considering surgery after that, potentially sooner, potentially 6 months, depending on that's surgeon preference. Bariatrics, we all know obesity is a risk factor for developing spinal issues, but also increases your risk of having surgery, of infection, reherniation, etc. So We have a streamlined pathway to get the patient a consult with obesity medicine, bariatric surgery for BMI greater than 35. Of course, if a patient comes in with severe myelopathy, can't walk, severe myelomalacia, you're going to, not have time, unfortunately, to go through this pathway. But for any elective spine surgery, this is the way to go. Nutrition, frailty. This is something we've increasingly identified the significance of. And I think that, to get the patient plugged in with geriatric medicine, if the patient is frail, we use something called the frail scale. It's as simple as can be. It's 5 questions. For example, can you go up a flight of stairs? Among others. And if it's 5 questions, you can tell if the patient's frail. If they're frail, you can get them plugged in quickly with a geriatric medicine consult. Infection prevention. This was a very hot topic in our meetings, but the swabs for decolonization is going to end up being for surgeon preference, not standardized across all spine surgery. Hematology. This is really if the patient has anomalies on their preoperative values, we want to get them a hematology consult. But again, you don't want it to take 4 months and make a lot of phone calls. You want it to be a simple click of a button and they see a hematologist. Social work, we all know the value and importance of social work in spine surgery, in the pathway of spine surgery. And then pain. So this is another one that there's a lot of different schools of thought. My opinion is irrelevant here, but I would just say that my patients, if they're taking more than 40 morphine equivalents per day, they're going to get a pain management consult pre-op. But to standardize across all spine surgeons, if they're taking more than 90 morphine equivalents, they should be referred to pain management. Or if they have a history of difficult to manage post-op pain or undergoing a fusion instrumentation of greater than 3 levels. I'll go a little quicker because I do want to leave time for Amanda or Jeremy to speak, or if there's any questions. But the admission order set, we already have a good order set. We've just fine-tuned it to make it a little more efficient, because that's the whole theme here is that we're trying to add efficiency. So patient skin prep, positioning, pain management, infection prevention, IV access, blood management. These are all things that I think we're all doing already, but they're we can dive deeper if there's any questions. Anesthetic, glucose control before closure. These are all really important, but I think for the most part, I don't want to dwell on this one too much because this is kind of what we're doing for the most part already. Post-op, this one was near and dear to my heart. I think there's really good evidence that if you get patients out of bed sooner, they're going to do better. So post-op day 0 out of bed is going to be instituted for everyone whose surgery is before noon. Or if possible, if you finish at 1, I know the residents know that if we finish surgery, we really try to get PT to see the patients the day of surgery, and it sometimes involves a phone call, but hopefully that's not going to involve a phone call and asking for a special favor, but it's just going to be done. PT once per day or twice if appropriate. Geriatric or medical management post-op, that really depends on the patients, but anybody 75 above and frail is going to have a geriatrics consult. This is something that I observed at HSS, and it's very, I think, valuable because I don't think we're experts in elderly care as neurosurgeons or orthopedic surgeons, and to have a little input in the 27 medications that the patient's taking, I think can really be valuable. Pain management, this obviously also was a source of a lot of discussion. And of course, it's very hard to get 6-8 people weighing in and standardizing pain control. But this is what we came up with, hydromorphone IV PCA for 24 hours after surgery. Not for everybody, but if they're meeting criteria for PCA. If patients on long-acting opioid medications at home, they should continue their home regimen. Upon discontinuation of the PCA. If opioid naive, oxycodone 510, this is kind of a lot of what we're doing already. Tramadol 50 Q4 PRN. Then there's another consider, right? We couldn't get, I think the residents know I like Toradol a lot. I think a lot of people I work with like celecoxib, but either way, these medications are extremely effective, and they also help you take less opioid, which in turn has lots of obvious benefit, including less constipation, shorter hospital stays, things like that. The topic of NSAIDs infusion is oft debated. I personally don't believe there's any strong evidence that NSAIDs impair fusion rates. Muscle relaxer, tizanidine or Flexeril, labs, CBC BNP for 3 days. Again, this is not for every patient. This is for patients who meet criteria. If you have a microdiscectomy, you're not going to be getting a CBC for 3 days. DVT prophylaxis, sequential compression devices for all cases. Again, a lot of this we're doing already. Bed board, I'll skip this, and social work, we already spoke about. I'm nearing the end here, so this is going to be, I think this is really relevant for when we actually unroll and unveil this, but it's going to be in the next few weeks, hopefully. But there's going to be a new order set, which basically involves everything we've already discussed. Spine surgery preoperative order set. This is used in the office. This is less relevant for the residents, unless in a clinic setting. More relevant for the attendings. There's going to be a preoperative order set, which again, this is not to add work to the spine surgeons or to the neurosurgeons preoperative workflow. It is going to improve efficiency. That was the thrust of everything that we've done. So what I would say is if any surgeon felt this was adding work, then they should give that important feedback. But we feel very strongly this is going to decrease work and increase efficiency and add value. Then the post-op order set, there is already an existing order set. There are mild changes to that. And then as there already is, there's 3 pathways. There's ambulatory, DAS, and inpatient. And we'll use these order sets. I think we already touched on everything on this slide and on this slide. We're gonna, this is the last slide, or the second to last slide. We're gonna track our metrics. I think the key one is response time. So let's say we're sending patients to endocrinology for a hemoglobin A1C of 8.5 or for a bone density of less than 2.5, and it's taking them 5 months. Then we're going to be tracking this, and we're going to say this is not working, and we're going to make it work by speaking with the heads of endocrinology, which we're already have had meetings with and are plugged in with. So it may not be perfect from the get-go, but we're going to be tracking it to make sure that it will become as close to perfect as possible. We're going to be also checking response time for physical therapy and time to ambulation, length of stay, discharge to home. We're hoping that all of these parameters are going to be improved by what we've done, right? If physical therapy sees your patients post-op day 0, they're much more likely to go home day 1 instead of day 2. And that's evidence-based as well, of course. Surgical site infections, if we're standardizing our antibiotics and our preoperative prep, hopefully we'll see a drop in infections as well. Our benchmarks, we're going to be comparing US News World Report Manhattan peer hospitals. And this is just an example of what the dashboard looks like. Time to first ambulation, post-op length of stay, discharge to home, length of stays, infections, readmissions. So these are the pivotal things that we're going to be monitoring and making sure that that what we've worked so hard to achieve ends up translating into a better provider experience, a better patient experience, and a more streamlined workflow for all patients who are having spine surgery at Mount Sinai. And with that, I'll end. I definitely want to know if Amanda or Jeremy have any thoughts or comments. And then, of course, there's time for questions. And just to, again, reiterate, this was not just me. This was the entire neurosurgery spine cohort, with particularly Tanvir and Khan attending as well.
I'll add a couple words. Thank you so much for the time today. Jeremy, that was fantastic. I think that, and I think you said it really well already, but just to reiterate that this is meant to drive outcomes and improve outcomes, but really also to make things easier for all of you. We listen to the things that you need help with, and those have been woven into the pathway. This is certainly iterative. So if you're finding that you still need help with certain things, there are areas for improvement, we could change that. If there are certain metrics that you want to explore, we can change that as well. Jeremy, I missed the first part of the presentation, so I don't know if you got into the patient-facing experience piece of it, but we are exploring a patient-facing app where you can collect data on mobility, on pain management, and we can use that information to drive performance and to better understand. So a lot of potential here, and really grateful to be working with the team on this.
I don't think I've ever seen a process like this at Mount Sinai. And it's interesting that this basically started with spine, which is one of the most challenging of all. I'm deeply impressed by what you just did. I mean, this is something we've been speaking that I've heard talk of for a very, very long time. There are pathways for management of cerebrovascular disease and other things, but this is a particularly complex issue. Jeremy, what I did not quite get from this was on that consult slide. How are you going to make, where do those phone calls and timings get better? Because you still have a long list of consults that didn't look that different on the last slide from the first slide. So how does that get quickened and sped up?
So I think for example, in our order set, in the preoperative order set, let's say the patient's BMI is 42, then in your what you see is it's going to have ambulatory referral to bariatric surgery.
I see.
You click a button, and then we had to meet with Epic and figure out routing, right? That has to go to someone, and it has to go to someone who's going to see it and expedite an appointment and know that it's part of this pathway. But it's basically as simple as a click of a button, not a phone call.
I see. Wow. I mean, this is amazing. How did you get all these people to agree?
That was the hardest part, I think. And that's why I think there's certain things, again, where it says, consider this, consider this. Anytime it said consider, it means we couldn't get uniformity of opinion about it. But I think I was surprised at how much we did agree on. And I think that even some of those pain medication, I mean, that could have been, something we couldn't standardize anything, but we were able to. So I think a lot has been standardized in a good way with.
Well, that MME is a new concept to me. I guess it's been around for a while.
Yeah, I recently made an error. I didn't notice that my patient was on just 30 morphine equivalents for chronic schwannomatosis. And we did this intradural schwannoma resection, a little small case, and the patient had immense pain after surgery. I kept, trying to figure out why is he being so difficult. And then I realized I didn't reconcile the preoperative morphine that I didn't see. So I think that is so important. I have a very long, painful discussion with patients about weaning their opioids pre-op and why I think it's so important. And what I usually tell the patients is it's really for you, because after surgery, you're going to be miserable if you don't wean your opioids, because nothing we give you is going to work. That's something I really feel very strongly about, is opioid weaning, in addition to, for elective spine surgery, patients who smoke really shouldn't be getting it. And patients who are on 50 milliequivalents of morphine are going to have a very hard time if they don't have a weaning process with their pain management doctor.
It's fantastic.
Jeremy, I have a question. What are the expectations here for adherence to this pathway for both neurospine and orthospine surgeons? Is this a policy? Is it intended to be uniform? Like, how are we applying this?
So the ideal answer is that, because it's really going to make everything easier. And of course, there's always a growing pain. The first time you click through the order set, it might add time, but once you do it 3 times, it's going to save you time in the long run. So I'm hoping it's going to be very easily adoptable because of how it streamlines care in a more efficient way. But we also will be tracking utilization. And if I guess if people aren't using it, Amanda, I think probably we'll just speak to them about why they're not, and if there's anything we could do to rectify that. So I don't know if we're going to be getting rid of the old order sets, if they're not going to be in existence anymore, but we're strong. I would say we're strongly encouraging everyone to use it, and it will make your life easier.
Yeah, I mean, ideally, I think that's well said. I don't know that I have to be the bad guy, but happy to work with people always. If there are barriers or reasons why people are choosing not to, open to hearing what those reasons may not to use the order set, open to hearing that as well. But ideally, we would get everybody on this pathway and retire the old order sets.
Amanda, has this been done for other interdisciplinary services?
It has, not many, but the joint pathway was a similar process. Bariatrics had a similar process, cardiac surgery as well. This is the first time, though, that two departments have gotten together to collaborate and create a singular pathway for a disease state the first time.
Awesome. Very powerful.